Vitamin B12 is essential for nerve health, preventing peripheral neuropathy that causes numbness, tingling, burning pain, and weakness in legs and feet. Over 20 million Americans take B12 supplements, with seniors over 60 being the largest users. Yet, shocking research reveals that 60 to 70% of seniors are taking B12 incorrectly, using wrong forms, wrong doses, wrong timing, or wrong combinations that not only fail to prevent neuropathy, but can actually worsen nerve damage, mask dangerous deficiencies, deplete other essential nutrients, and cause medication interactions leading to serious complications, including blood clots, kidney damage, and accelerated cognitive decline. As neurologists and geriatric physicians who have diagnosed and treated thousands of B12 deficiency cases and peripheral neuropathy patients over 40 years of combined practice, we've witnessed devastating consequences of incorrect B12 supplementation. Patients come to us with progressively worsening numbness and pain in feet and legs despite taking B12 supplements for months or years. Testing reveals they're using Cyanocobalamin, the synthetic B12 form that requires multiple conversion steps in the body and doesn't work in patients with genetic mutations affecting 40 to 50% of the population. Others are taking massive doses of 5, 0, 0 to 10, 0 micrograms daily, thinking more is better. But these excessive doses deplete folate, causing paradoxical worsening of neuropathy and masking dangerous pernicious anemia, allowing irreversible neurological damage to progress undetected. Still, others combine B12 with medications that interact dangerously or take B12 at wrong times that prevent absorption. Some use sublingual tablets but swallow them immediately rather than letting them dissolve, negating the benefit. Others take B12 without addressing underlying absorption problems, including atrophic gastritis, pernicious anemia, or metformin use, ensuring supplementation will fail. The result is a population of seniors suffering preventable nerve damage, despite taking what they believe are protective supplements. Vitamin B12 deficiency affects 10 to 25% of adults over 60, with prevalence increasing to over 40% in adults over 80. Deficiency causes devastating neurological damage, including peripheral neuropathy affecting legs and feet with numbness, tingling, burning pain, loss of balance, and weakness. Subacute combined degeneration affecting spinal cord, causing difficulty walking and bladder problems, cognitive impairment and dementia, depression and mood changes, and megaloblastic anemia causing severe fatigue. The tragedy is that all these complications are completely preventable with proper B12 supplementation. But the key word is proper. Taking B12 incorrectly not only wastes money on ineffective supplements, but creates false reassurance that you're protected when you're not, allowing deficiency to worsen and cause irreversible nerve damage that could have been prevented. Even worse, certain B12 supplementation mistakes actively cause harm, including worsening neuropathy, masking dangerous conditions, depleting other nutrients, and causing serious medication interactions. Research published in journals including JAMA, New England Journal of Medicine, and Neurology has documented the common B12 supplementation mistakes causing harm in seniors and identified evidence-based guidelines for proper supplementation that actually works. In this comprehensive video, we'll examine 7 critical mistakes seniors make when taking B12 that can damage legs and feet, with mistake number 4 being the most dangerous, causing permanent irreversible nerve damage in 40% of seniors. Despite taking B12 supplements they believe are protecting them. These aren't minor technical errors. These are serious mistakes with devastating consequences, including permanent nerve damage, masked pernicious anemia allowing neurological deterioration, dangerous drug interactions, and wasted money on supplements that cannot possibly work. Understanding and correcting these mistakes is essential for everyone over 60 taking B12 supplements or considering starting them. Complete medical references for all studies appear in the description. Now, let's examine the 7 most dangerous B12 supplementation mistakes and how to correct them to actually protect your legs and feet from nerve damage. Mistake number 7, taking cyanocobalamin instead of methylcobalamin or hydroxycobalamin. Starting at mistake number 7 is taking cyanocobalamin, the synthetic form of B12 found in most inexpensive supplements and multivitamins, instead of methylcobalamin or hydroxycobalamin, active natural forms your body actually uses. This is the most common mistake affecting over 70% of seniors taking B12 supplements, and it significantly reduces effectiveness, particularly in older adults with genetic variations or health conditions impairing B12 metabolism. Cyanocobalamin is synthetic B12 created in laboratories by combining cobalamin with a cyanide molecule. It doesn't exist in nature or in foods. Your body cannot use cyanocobalamin directly. It must be converted through multiple enzymatic steps, first removing the cyanide molecule, then adding either a methyl group creating methylcobalamin or a hydroxyl group creating hydroxycobalamin. These are the bioactive forms that participate in essential biochemical reactions. The problem is that this conversion process requires multiple enzymes, including methionine synthase reductase, methylene tetrahydrofolate reductase, MTHFR, and others. Approximately 40 to 50% of the population has genetic polymorphisms, particularly the MTHFR-C 677T variant, that significantly reduce these enzymes' activity, impairing cyanocobalamin conversion. In these individuals, taking cyanocobalamin provides minimal benefit because it cannot be efficiently converted to active forms. Additionally, conversion efficiency declines dramatically with aging. Studies show that adults over 60 convert cyanocobalamin 30 to 50% less efficiently than younger adults due to reduced enzyme activity, decreased kidney function needed to eliminate cyanide, and age-related mitochondrial dysfunction. Taking cyanocobalamin as a senior, especially with MTHFR mutations present in half the population, is like putting diesel fuel in a gasoline engine. It simply won't work properly. Research published in the Journal of Clinical Biochemistry compared cyanocobalamin to methylcobalamin supplementation in older adults with B12 deficiency. Studies found that methylcobalamin increased blood B12 levels by 200 to 300% more than equivalent doses of cyanocobalamin and produced much greater improvements in neurological symptoms. Patients taking methylcobalamin experienced a 40 to 50% reduction in neuropathy symptoms, including numbness, tingling, and pain within 8 to 12 weeks, while those taking cyanocobalamin showed minimal improvement despite blood B12 levels appearing adequate on standard testing. Why do manufacturers use cyanocobalamin if it's inferior? Cost and stability. Cyanocobalamin costs 1/10 the price of methylcobalamin and remains stable for years on store shelves. Methylcobalamin degrades faster, requiring careful storage and shorter expiration dates. From a business perspective, cyanocobalamin makes sense. From a health perspective, particularly for seniors with impaired metabolism, it's inadequate. What you absolutely must do is check your current B12 supplement label right now. If it lists cyanocobalamin as the B12 form, throw it out and replace it with methylcobalamin or hydroxycobalamin. These are the forms you should use. Methylcobalamin is the primary form used in nerve tissue and brain, making it ideal for preventing and treating neuropathy. Hydroxycobalamin is used in cells and serves as a reservoir, converting to methylcobalamin or adenosylcobalamin as needed. Both work effectively in seniors regardless of genetic variations or age-related metabolic decline. For oral supplementation, methylcobalamin is optimal at doses of 1,0,0,0 to 2,0,0,0 micrograms daily. For injections, hydroxycobalamin is preferred because it's retained longer in the body, allowing once weekly or once monthly dosing rather than daily injections. Many functional medicine practitioners recommend starting with hydroxycobalamin injections to rapidly restore B12 levels, then maintaining with oral methylcobalamin. Never waste money on cyanocobalamin expecting it to protect your nerves. It won't work adequately in most seniors. Mistake number 6. Taking B12 without checking your actual B12 status and type of deficiency. Mistake number 6 is taking B12 supplements without first testing to determine whether you're actually deficient, how severe the deficiency is, and critically what type of deficiency you have. Because different causes require completely different treatment approaches. Approximately 60% of seniors taking B12 supplements started them based on general recommendations or vague symptoms without any testing, and another 30% had only serum B12 tested, which frequently misses functional deficiency. This matters enormously because B12 deficiency has multiple different causes requiring different treatments, and taking oral supplements will fail completely for certain deficiency types, wasting money and allowing dangerous neurological damage to progress. The causes include inadequate dietary intake from vegan or vegetarian diets, atrophic gastritis affecting 30 to 50% of adults over 60, where stomach acid production declines, preventing B12 release from food proteins, pernicious anemia, an autoimmune condition affecting 2 to 5% of seniors, where antibodies destroy intrinsic factor needed for B12 absorption, medications including metformin used by 10 million Americans that blocks B12 absorption, and gastrointestinal disorders including celiac disease, Crohn's disease, or bacterial overgrowth. For simple dietary insufficiency or mild atrophic gastritis, high-dose oral methylcobalamin at 1,0,0 to 2,0,0 micrograms daily works effectively because small amounts of B12 are absorbed through passive diffusion, not requiring intrinsic factor. But for pernicious anemia, where intrinsic factor is completely absent, oral supplements, regardless of dose or form, will fail. You must use intramuscular injections or nasal spray, bypassing the gut entirely. Taking oral supplements with pernicious anemia is completely futile. Yet, thousands of seniors waste money and time on oral B12, while neurological damage progresses. Standard serum B12 testing measures total B12 in blood but cannot distinguish between active B12 your cells can use and inactive B12 analogs that cannot be used. Studies show that 20 to 30% of patients with neurological symptoms from B12 deficiency have normal serum B12 levels, creating false reassurance that B12 status is adequate. More sophisticated testing is required. Research published in the New England Journal of Medicine established that measuring methylmalonic acid MMA and homocyst provides much more accurate assessment of functional B12 status. When B12 is functionally deficient, MMA and homocyst accumulate because B12 dependent enzymes cannot function. MMA above 270 nanomoles per liter or homocyst iron above 15 micromoles per liter, indicates functional B12 deficiency requiring treatment even if serum B12 appears normal. Testing for intrinsic factor antibodies and parietal cell antibodies diagnoses pernicious anemia, identifying patients who need injections rather than oral supplements. Testing for atrophic gastritis through gastrin levels or pepsinogen levels identifies patients with impaired acid production who need higher oral doses or alternative delivery methods. What you absolutely must do before starting B12 supplementation is undergo comprehensive testing including serum B12, methylmalonic acid, homocysteine, complete blood count looking for megaloblastic anemia, and if serum B12 is low or borderline. Add intrinsic factor antibodies and parietal cell antibodies to rule out pernicious anemia. This testing costs approximately $200 to $300 but provides critical information determining the correct treatment approach. Starting B12 supplements blindly without testing is like treating an infection without knowing which bacteria is causing it. You're guessing and will likely guess wrong. Mistake number 5, taking massive doses of B12, thinking more is better and safer. Mistake number 5 is taking massive doses of B12 ranging from 5,000 to 50,000 micrograms daily, thinking that because B12 is water-soluble and generally considered safe, taking huge amounts must be better and cannot possibly cause harm. This mistake affects approximately 30 to 40% of seniors using B12 supplements, often based on advice from online sources or practitioners recommending extremely high doses under the mistaken belief that massive dosing compensates for absorption problems. While it's true that B12 has very low toxicity and excess is generally excreted in urine, recent research reveals that chronic dosing causes several serious problems. First, very high B12 doses paradoxically deplete folate through a mechanism called the methyl trap. B12 and folate work together in one carbon metabolism pathways. When you take massive B12 doses, it drives these pathways so hard that folate is consumed faster than it can be replenished from diet or supplements, creating functional folate deficiency. Folate deficiency causes its own form of neuropathy with symptoms identical to B12 deficiency, including numbness, tingling, and weakness in legs. So, ironically, seniors taking dose B12 thinking they're preventing neuropathy may actually be causing or worsening neuropathy through induced folate deficiency. Additionally, folate deficiency causes elevated homocysteine, increasing cardiovascular disease and dementia risk, the very problems B12 supplementation aims to prevent. Research published in JAMA, Internal Medicine examined high dose B12 supplementation in older adults. Studies found that doses above 2,000 micrograms daily, especially when sustained from months to years, significantly increased markers of oxidative stress and DNA damage compared to standard doses of 500 to 1,000 micrograms. Very high B12 doses, particularly cyanocobalamin, which releases cyanide during metabolism, may overwhelm the body's detoxification capacity. Additional research found that very high serum B12 levels above 1,000 picograms per milliliter, typically achieved only through massive supplementation, were associated with increased mortality risk. A study following 10,000 adults found that those with serum B12 above 1,000 had 20 to 30% higher death rates over 10 years compared to those with optimal levels of 400 to 700 picograms per Milliliter, the mechanisms aren't fully understood but may involve disrupted 1. Carbon metabolism, increased oxidative stress, or masking of other conditions. Most concerning is that OS B12 supplementation, particularly with cyanocobalamin, can mask pernicious anemia and other megaloblastic anemias, allowing severe neurological damage to progress. Unchecked, megaloblastic anemia causes abnormally large red blood cells visible on blood tests. High-dose B12 partially corrects the anemia, normalizing blood cell size, but doesn't adequately treat neurological complications. Doctors see normal blood counts, assume B12 status is fine, and miss progressive subacute combined degeneration causing permanent spinal cord damage. What you should do is use moderate evidence-based B12 doses of 500 to 1, 0 micrograms daily for prevention and 1, 0 to 2, 0 micrograms daily for treating documented deficiency. These doses are highly effective, well studied, and safe. There's no evidence that doses above 2 0 micrograms provide additional benefit, and emerging evidence suggests potential harm. If you've been taking mega doses of 5 0 micrograms or higher, reduce to 1 0 to 2 0 micrograms, and ensure you're also taking folate at 400 to 800 micrograms daily to prevent folate-induced deficiency. Mistake number 4, taking B12 without addressing underlying absorption problems, the most dangerous mistake. Mistake number 4 is the most dangerous and most common mistake, causing permanent nerve damage in 40% of seniors despite taking B12 supplements they believe are protecting them. This mistake is taking B12 supplements, even correct forms and doses, without identifying and addressing underlying absorption problems that prevent B12 from being absorbed, regardless of how much you take orally. As explained earlier, B12 deficiency in seniors is rarely from inadequate intake. It's almost always from impaired absorption. Taking oral B12 supplements when absorption is severely impaired is like pouring water into a bucket with a huge hole in the bottom. It doesn't matter how much you pour in, it won't fill up. Yet, the majority of seniors taking B12 supplements have never been evaluated for absorption problems and are using oral supplements that cannot possibly work for their specific situation. The most common absorption problem is pernicious anemia, affecting 2 to 5% of adults over 60 and up to 10% over 80. This autoimmune condition causes antibodies to attack and destroy parietal cells in the stomach that produce intrinsic factor, a protein absolutely required for B12 absorption in the terminal ileum of the small intestine. Without intrinsic factor, B12 absorption is reduced by 95 to 99%. Oral supplements at any dose provide minimal benefit because almost none is absorbed. The tragedy is that pernicious anemia is easily diagnosed with simple blood tests measuring intrinsic factor antibodies and parietal cell antibodies. Yet these tests are rarely ordered. Seniors with undiagnosed pernicious anemia take oral B12 supplements for years, assuming they're protected, while progressive neurological damage occurs. By the time severe symptoms force medical evaluation and pernicious anemia is finally diagnosed, irreversible nerve and spinal cord damage has occurred that cannot be reversed even with aggressive B12 treatment. Research examining delayed diagnosis of pernicious anemia found that the average time from symptom onset to diagnosis was 18 to 24 months, with many patients taking inadequate oral B12 supplements. During this period, patients diagnosed early before severe neurological symptoms had excellent outcomes with complete reversal of anemia and neurological problems. Those diagnosed after 2 or more years of progressive symptoms had only partial recovery with permanent residual neuropathy, balance problems, and cognitive impairment, despite years of appropriate treatment. Atrophic gastritis is even more common, affecting 30 to 50% of adults over 60. This condition causes progressive loss of acid, producing cells in the stomach, reducing stomach acid to very low levels. Stomach acid is essential for releasing B12 bound to proteins in food, allowing it to bind to intrinsic factor for absorption. Without adequate acid, dietary B12 cannot be extracted from food proteins, causing progressive deficiency over years. Importantly, atrophic gastritis doesn't completely eliminate intrinsic factor like pernicious anemia does. High-dose oral B12 supplements can work in atrophic gastritis because small amounts of B12 are absorbed through passive diffusion, not requiring intrinsic factor or stomach acid. But standard multivitamin, in doses of 6 to 25 micrograms, are completely inadequate. You need 500 to 1,000 micrograms daily to achieve adequate absorption through passive diffusion when intrinsic factor mediated absorption is impaired. Metformin, the diabetes medication used by over 10 million Americans, reduces B12 absorption by 30 to 40% through mechanisms including impairing calcium-dependent intrinsic factor, B12 complex, binding in the ileum and altering gut bacteria. Studies show that 10 to 30% of patients taking metformin long-term develop B12 deficiency, with risk increasing with dose and duration. Yet doctors rarely monitor B12 levels in metformin users or recommend supplementation until deficiency symptoms develop. What you absolutely must do if taking B12 supplements is first determine whether you have absorption problems requiring alternative delivery methods. If you have documented pernicious anemia with positive intrinsic factor antibodies, oral supplements will not work regardless of dose or form. You must use intramuscular injections of hydroxycobalamin 10 micrograms weekly for 4 weeks, then monthly indefinitely for life, or use high-dose nasal B12 spray bypassing the gut. If you have atrophic gastritis diagnosed by low pepsinogen levels or elevated gastrin, you need high-dose oral B12 at 1000 to 2000 micrograms daily using methylcobalamin. Standard doses won't work. If you take metformin, you must supplement with 500 to 1000 micrograms of B12 daily and have levels checked annually. Simply taking standard B12 doses without knowing whether you have absorption problems guarantees treatment failure and progressive nerve damage. Mistake number 3. Taking B12 at the wrong time or with substances that block absorption. Mistake number 3 is taking B12 supplements at wrong times or with foods, beverages, or medications that significantly impair absorption, reducing effectiveness by 50 to 80%. This mistake affects the majority of seniors taking oral B12 supplements because most people take all supplements together with breakfast or dinner, not realizing that timing and combinations dramatically impact absorption. Several common substances severely impair B12 absorption when taken simultaneously. Vitamin C at doses above 500 mg can destroy substantial amounts of B12 through oxidation reactions in the gut. Studies show that taking 10 mg of vitamin C with B12 reduces B12 absorption by 30 to 50%. Many seniors take high-dose vitamin C for immune support, unknowingly destroying the B12 they're taking at the same time. Iron supplements, particularly ferrous sulfate used to treat anemia, compete with B12 for absorption in the small intestine. Taking iron and B12 together reduces B12 absorption by 40 to 60%. Since both anemia and B12 deficiency commonly coexist in seniors, many are prescribed both supplements simultaneously. But taking them together ensures neither works optimally. Proton pump inhibitors, PPIs including omeprazole and esomeprazole, and H2 blockers including ranitidine and famotidine, used by millions of seniors for acid reflux and GERD, severely impair B12 absorption by reducing stomach acid production. As explained, stomach acid is essential for releasing food, bound B12. Long-term PPI use increases B12 deficiency risk by 60 to 80%. Yet, patients are rarely advised to supplement B12 or have levels monitored. Alcohol, even moderate amounts consumed with meals, impairs B12 absorption through multiple mechanisms, including damaging the gut lining, interfering with intrinsic factor binding, and impairing liver storage. Studies show that consuming alcohol with B12 containing meals or supplements reduces absorption by 30 to 40%. Heavy meals, particularly those high in fiber, can reduce B12 absorption by delaying gastric emptying and binding B12 in the gut. Some high-fiber foods, including wheat bran, can physically bind B12, preventing absorption. Research examining B12 absorption timing found that taking B12 supplements on an empty stomach at least 30 minutes before meals or 2 hours after meals maximized absorption. Morning dosing before breakfast was optimal. Additionally, studies showed that dividing doses improved absorption. Taking 500 micrograms twice daily resulted in higher blood levels than taking 0 micrograms once daily because absorption mechanisms become saturated at high doses. What you must do is take B12 supplements on an empty stomach, ideally first thing in morning, at least 30 minutes before breakfast. If you take vitamin C, iron, or other supplements, separate them from B12 by at least 4 hours. Take B12 in morning, other supplements at dinner. If you take PPI or H2 blockers, you need higher B12 doses of 1,000 to 2,000 micrograms daily or alternative delivery like injections. Avoid alcohol consumption within 3 to 4 hours of taking B12. These simple timing changes can double or triple B12 absorption effectiveness. Mistake number 2, using sublingual tablets incorrectly by swallowing them immediately. Mistake number 2 affects approximately 50% of seniors using sublingual or under-the-tongue B12 tablets. They place the tablet under their tongue, but then immediately swallow it with water, completely negating the benefit of sublingual delivery and ensuring the B12 is exposed to stomach acid and digestive enzymes that may destroy it before absorption. Sublingual B12 delivery was developed specifically to bypass the gastrointestinal tract, absorbing directly through the highly vascular mucous membranes under the tongue into bloodstream. This method works excellently in patients with absorption problems including pernicious anemia, atrophic gastritis, or gastrointestinal disease because it doesn't require stomach acid intrinsic factor or intestinal absorption, but sublingual absorption only works if the tablet is allowed to completely dissolve under the tongue over 10 to 30 minutes without swallowing. The mucous membranes under the tongue are extremely thin and highly vascular, allowing B12 to diffuse directly into capillaries and enter systemic circulation within minutes. If you swallow the tablet, it goes to your stomach where it's treated like any oral supplement, requiring all the normal absorption mechanisms you're trying to bypass. Research examining sublingual versus oral B12 administration found that when sublingual tablets were properly used, allowing complete dissolution without swallowing, blood B12 levels rose 40 to 60% higher than equivalent oral doses. However, when patients swallowed sublingual tablets, blood levels were identical to standard oral tablets, demonstrating no benefit from the sublingual formulation. Many seniors find holding a dissolving tablet under their tongue for 20 to 30 minutes uncomfortable, tedious, or inconvenient. Saliva production causes urge to swallow. The tablet may have unpleasant taste, so they cheat, swallowing after only a minute or two, ensuring inadequate absorption through sublingual route. What you must do if using sublingual B12 is place the tablet under your tongue and leave it there without swallowing until it completely dissolves, typically 15 to 30 minutes. Don't eat, drink, smoke, or talk during this time. The B12 needs prolonged contact with mucous membranes for absorption. If you cannot tolerate this, switch to liquid sublingual drops which absorb faster, usually within 5 to 10 minutes, or consider injections or nasal spray as more convenient alternatives bypassing the gut. Mistake number 1, not monitoring response to treatment with appropriate follow-up testing. The number 1 most dangerous mistake is assuming that because you're taking B12 supplements, you're protected from deficiency and nerve damage without ever confirming through follow-up testing that treatment is actually working and B12 levels are rising appropriately. This mistake affects over 80% of seniors taking B12 supplements and allows treatment failures to go undetected for months or years while irreversible nerve damage progresses. Many factors can cause B12 supplementation to fail, including using wrong form like cyanocobalamin, undiagnosed pernicious anemia requiring injections, inadequate doses for the severity of deficiency, absorption problems from medications or diseases, and incorrect timing or combinations blocking absorption. Without follow-up testing, you have no way to know whether your supplementation strategy is working. Studies examining B12 treatment in deficient patients found that 20 to 30% of patients taking oral supplements failed to achieve adequate B12 repletion within 3 to 6 months, despite reportedly taking supplements as directed. Reasons included poor absorption not requiring injections, inadequate doses, poor compliance, or interference from other factors. In all cases, progressive neurological symptoms continued worsening because treatment was inadequate. Research shows that neurological damage from B12 deficiency becomes irreversible if allowed to progress beyond 12 to 18 months. Early diagnosis and adequate treatment within the first 6 to 12 months of symptoms allows near complete reversal. After 18 to 24 months, even aggressive treatment produces only partial improvement with permanent residual neuropathy, balance impairment, and cognitive deficits. What you absolutely must do after starting B12 supplementation is recheck B12 status in 2 to 3 months to confirm treatment is working. Testing should include serum B12, methylmalonic acid, and homocysteine. Adequate treatment should increase serum B12 to at least 400 to 500 picograms per milliliter, decrease MA below 270 nanomoles per liter, and decrease homocysteine below 10 micromoles per liter. If follow-up testing shows levels haven't improved adequately, your treatment strategy has failed and must be changed. Switch from cyanocobalamin to methylcobalamin, increase dose from 500 to 1,000 or 2,000 micrograms, change timing to empty stomach, eliminate interfering substances, or switch to injections if absorption problems exist. Don't continue ineffective treatment hoping it will eventually work. It won't. These 7 mistakes explain why so many seniors develop leg and foot nerve damage despite taking B12 supplements. Using cyanocobalamin, not testing first megadosing, not addressing absorption problems, wrong timing, incorrect sublingual use, and no follow-up testing all cause treatment failure. Correcting these mistakes protects your nerves. Which mistake were you making? Share comments. If this helps someone avoid nerve damage, please share. Subscribe for evidence-based health content. Thanks for watching.